Good afternoon, ladies and gentlemen. I think now it's time to talk about the newest kid on the block, the presbyopic lenses. Dr. Sujata has kind of made my work easier. She's talked about dry eye, which does form a major part of multifocal practice. Over the last decade or so, we have seen a tremendous wave of change. Things are definitely looking up. The advances in the technology and the equipment have been phenomenal. But at the same time, I would say there is a massive change in the human psychology and the way we as humans feel and see things. Let me show you what I mean. I think this proverb describes it best. There was a time when a cataract patient would sit at home until he was nearly blind, harboring hard, mature cataracts. Then he would come to the ophthalmologist who would operate him by the ECC technology, mind you, give him 5 sutures and a big fat astigmatism. The result still was a blissfully happy patient. I think over time, the surgical methods have improved. The postoperative astigmatism has reduced nearly to nothing. But then one would expect the emotional state of the patient should be exquisitely happy, right? Well, sometimes it's not so. Patients today are more aware about their health and their health needs. Many walk in the OPD with just a minimal disturbance in their eyes, and they expect us to make it better in some way or the another. So no pressure, folks. So in this high demanding, challenging world, we as ophthalmologists have sometimes to play a role of a matchmaker between a good IOL and a patient. Let's see how we do it at Lakshmi. When a patient walks in our OPD with complaints of diminution of vision and a desire to have freedom from glasses, he gets considered for the presbyopic lenses. There is a strict protocol which we follow so that we don't miss out on anything, and which if we do, then might result in a potentially unhappy patient. A multifocal IOL will do well, the patient will be happy when it is chosen for the correct patient in whom all the optical media are normal, so the tear film being the first optical media. If the astigmatism in the eye is regular and correctable, and an eye which probably should have minimal aberrations, of course it can't be perfect, and the post-operative residual error after surgery should be around plus to minus 0.25 diopters. So let's start the investigation. After the stop at the optometrist, the patient is seen for a thorough clinical examination on the slit lamp. Certain findings may cause some hindrance in the success of multifocal IOLs, these being severe blepharitis, which Madam also explained a bit more in detail. These can cause dry eye and an unstable tear film, increasing the aberrations and then the poor vision. Corneal dystrophies, corneal scars or opacities, any zonular weaknesses in the lens, again can lead to an unstable bag for implantation, and finally retinal dystrophies, which can cause abnormal or reduced contrast sensitivity, which even further worsens the case. The next most crucial evaluation for dry eye that we have today is the ocular surface analyzer, which again Madam has explained in detail. There are many different models of it. We also have one. These dry eye can most often be picked up or just on a slit lamp clinical examination, but one must look for it. I think most of us don't think of it as very important. A machine like the OSA makes this task easy because it gives an objective report on the status of the glands or the breakup time. So the report states whether is it in a red or a green or a yellow marking, and depending on that, we have to start treatment at least 2 to 3 weeks before our surgery. In this scan, you can see that the meibomian glands can be seen, and then there is a scale, whether is it in an okay state or is it going into the red areas. Then the tear butt is measured as well as the lipid layer, which is shown on the lower slide, and even the tear meniscus can be objectively recorded. This is the final report which comes in the machine. Here it is telling us that the right eye is showing a little low lipid layer and a tear meniscus. But what most importantly it tells us is that it differentiates the dry eye, whether is it an evaporative one or because of a meibomian gland disease. Now with this objective method, the treatment then becomes more methodical. Then we can plan in a better way. The next on the list is biometry. We can do this to get the exact measurements of the eye so as to calculate the IOL power. Again, Dr. Shetty has extensively covered how and which IOL formulae work best today. But as of now, we have 3 main biometers to work with. We have the IOL Master 500. It measures 6 points at the 2.3 zone. Then the next is the Lenstar LS 900, which measures 16 points at 2 zones. And then the newest, which is the IOL Master 700, which is working on a swept source OCT technology. It can actually see the fovea, so you can get a very accurate axial length measurement. All of these also calculate the K, anterior chamber depth. Certain machines are more evolved, so they calculate the central corneal thickness, the lens thickness, white to white. So many other parameters are seen. Corneal topography, a very, very important tool in the armamentarium for multifocal IOL lens practice. Remember when I said, when will a multifocal lens work best? When the astigmatism in the eye is least. So we have to correct it if there is a high astigmatism in the eye. So any astigmatism which is more than 0.75 again hinders. So that's why this helps. What it does is it gives you the power of the astigmatism. It tells us about the axis of it. It lets us know whether is it a regular cylinder, is it going to be correctable. Then a very important data that it provides is the posterior corneal astigmatism. And I think as a refractive surgeon, I should add that it tells me what is the central corneal thickness of that eye. Because in case after everything, if the patient is going to have some residual error, I can probably do a re-enhancement or a touch-up so that he's happy after surgery. So what are the corneas that we will encounter in a practice? A symmetric bow tie, which will do well with a toric IOL. An asymmetric bow tie, they may do well, with which probably has with the inferior steepening, but may not get complete correction. So this has to be mentioned to the patient maybe beforehand. Then an irregular pattern, this is unlikely to benefit from a toric IOL, let alone a multifocal IOL. So we won't go there. Next on the list is a very interesting machine called the iTrace. It has a patented ray tracing technology which measures the optical aberration through the analysis of the retinal spot diagram. Now, up till now, we were able to detect only the lower order aberrations, that is the spherical error and the astigmatism, and obviously we could correct them by refraction. But what about the multitudes of higher order aberrations which were present in many eye and causing the disturbances? With iTrace, we could detect them now. It is essentially a 5-in-1 system. It has an aberrometer, topographer, autorefractometer, and it also measures the pupil size. Essentially, the ray tracing detects the total eye aberrations. The Placido disc is measuring the corneal aberration, and by subtracting the two, we are getting the internal eye aberration. So now the fun starts. Let's look at this eye. The lines here, the blue lines that you can see, are coming from the internal optics. That is probably from the lens. And then we can see from some coming from the cornea, that they are not so many. And then because of the high internal optical aberrations, you can see that the entire eye is also showing high aberrations. This could mean that the aberrations are because of an IOL or a cataractus lens. In this eye, he was a phakic person who had come to us with complaints of glare because of a very early cataract. So that's why the aberrations are seen. Now this machine also has a IOL selection guide which has a checklist. So there are some questions on the left side. It may not be clear. Let me read those out. It asks the machine, is the eye tracy refraction normal? Now in this slide, in this case, the refraction was not normal. It was about plus 7.87 minus 8. Then the next question, are there corneal higher order aberrations present? So internally, everything is seen. On the cornea, there are not so many. So the answer is no. Are internal higher order aberrations present? Yes, a lot of them. You could see a lot of crowding, or it is all in the inside of the eye. So based on these three questions, they go next to see the angle alpha, which in this case is 0.5. And the astigmatism is also considered. It tells you which lens to implant in this patient. This is not a hard and fast rule, but it does give you a lot of assistance. It can be your complementary machine to see. So in this patient, you could consider a premium IOL, that is a multifocal IOL, or a monofocal non-toric IOL, or simply an aspheric IOL. Now to show how eye tracing can be helpful in a multifocal IOL practice, let me exhibit this case. He came with complaints of diminution of vision and was detected in cataracts in both eye. He wished for a multifocal IOL. As a protocol in our institute, we let the patient undergo all of these tests. So obviously the eye tracing was also done. But as bad luck would have it, we missed seeing this test. It's not that it all comes to us in our hands. We have to physically go and see it on the machine. For some reason or the other, it was not seen before the implantation. We went ahead with it. The patient had both the eyes operated, and then he came back to us with a month later with complaints of some starburst. He was not very happy. Now we did his post-op eye tracing scans. This is after a month. What we can see is that there are some higher order aberrations coming from the internal optics. They are not a lot, but they are there. Then the corneal aberrations which weren't present, but again are there, again very low. It can be because of the incisions or just a dry eye postoperatively also. But the important point to note here is the angle of alpha. So let me go back here. The angle of alpha which is seen there is almost 0.640. The normal angle alpha to note is less than 0.5. So if we probably would have seen this patient before implanting, we may not have gone ahead with a multifocal IOL. Then we went back and checked for the IOL selection analysis for this patient, and the machine said that the lenses to consider were only a spherical IOL or a balanced curve IOL. So what we essentially tells us that multifocal IOL was not even to be considered. This is the image on the eye trace showing the angle alpha, the angle kappa, and the visual axis. In this patient, it was large. It was 0.6540. So this was not a good patient for a multifocal IOL implant. And the internal aberrations were because of a few PC folds that we saw clinically, and probably we could treat him by doing a yak cap, and he might have become a little better. But more importantly, he was unhappy because of the large angle. Next up on the list is an OCT macula, which we do for all patients. We want to know if there are any conditions which could reduce the contrast sensitivity even more after the implant. Pupil plays a very important role in deciding which multifocal IOL will be preferred. An apodized multifocal, which has a better distance near distribution, can be preferred in a dim light when the pupil becomes a little large. A person having around 7 mm pupil should be told that at night he may experience some glares or halos. In case of a small pupil, the patients can be counseled, again, that he may have a little poor near vision, so he may dim the light a bit, and that might help him. But now let's look at the patient's personality that we are dealing with. All throughout the examination, we have to keep our eyes and ears open. Ask him about his daily activities. What does he like? What are his hobbies? What is his tolerance for nighttime dysphotopsia? Now, has the patient complained at any stage? You are making him go through a list of investigations. Is he impatient about getting any of things done? Now, what is happening is that the patient is giving us red flags at each stage. We just have to pick them up. Because finally, a happy patient is going to be who? A hyperopic guy with a happy temperament who enjoys watching television and has his outdoor activities, reads occasionally, and then an icing on the cake would be that he hasn't noted a change in his spectacle prescription. So he is your happy patient. Before undergoing any surgery or even selecting a multifocal IOL for them, I think that we should subject the patient to this questionnaire. I believe this makes the patient share their responsibility of the postoperative outcome. The questions in this are about which preference of distance he would like, at which he may have good vision. Is he happy if he has a little less vision for near or intermediate or distance, depending on his lifestyle? I think looking at this, we can assess if the patient would be happy or not. All of these tests may look time-consuming, intimidating, but believe me when I say that it is better to spend 3 hours before surgery than after. A comprehensive fixed protocol helps everyone in the hospital to work seamlessly, and it avoids any waste of time. We can then take a well-informed decision about the type of lens to implant. We are actually spoiled for choices. There are a lot of multifocal IOLs in the market, but I think every surgeon needs to find which lens works best in his or her hand, and then take a call. With personal experience, we feel that these are the lenses which work well for good near vision, and these would work well for a good intermediate vision, and patients demanding very good vision for distance, we normally recommend these. For a short of time, I'm going to continue just to show you a quick look at how final touches can be added to fine-tune a multifocal IOL implant. This is the Varion image guiding system that we use for all our multifocal patients. It can give us input at every stage, right from the beginning. If there is a less than significant astigmatism, it still tells us where to put our side port incisions, where to put our main incision, and throughout the step, it guides us. So this is the guide which tells us where the main incision needs to go, then the side incisions. Then we can program our own rhexis size. Normally, we keep it at 6 so that we know we cannot go beyond that. We are always short of that size, because a good central rhexis will give a good centered lens into the bag, and again will have a stability will be improved. Once the lens is implanted into the bag, then we go ahead to look at the Purkinje images and to make sure that it is right in the center of the lens, which is again most significant part of the IOL implantation. Okay, so how do we avoid the drama? After all of this, if you land up in some trouble, remember to breathe, and then relying on your preoperative counseling, because that's most important. And then we will try to see in some way or the other how we can make the patient happy. I think in the end, we have to be confident about whatever decision that you have taken for the patient if you know that the lens works well in your hand. because undecidedness results in poor conversion rate. It doesn't give off your confidence to the patient, and he finally becomes more unhappy. And spending time, again, preoperatively results in less time post-operatively, can't be stressed more. Thank you so much.